So this talk, of course, it's obviously the audience is doctors, but I usually label it a citizen's perspective because it's important for us also as individuals to know how this plays out. So the learning objectives, normally there are only about 3, but here it's a long lecture, so there are 5. The first is recognize the dying process from chronic disease and from cancer, then to prognosticate, basically to learn how to prognosticate using surprise question and other tools, how to identify and assess symptoms that need to be addressed and to manage appropriate interventions to care for the actively dying, to understand the bereavement process, and finally to analyze the current medico-legal scenario. So let me begin by asking all of you, do we think about our own death, our own death? If it is, do we think about dying with pain and suffering? No, we usually don't. And if at all we think about death, we think of it the way Woody Allen did. He said, I'm not afraid of death. I just don't want to be there when it happens. And for us in palliative care, it is important to set boundaries. The first, the widest, is that of palliative care, which is applicable to all serious health-related suffering. Then the next is end-of-life care. Now, if you look at it, end-of-life care and terminal care obviously overlap. That definitely, but these are somewhat in retrospect. It's often not possible to determine in advance because these boundaries tend to be rather fluid. But actively dying is a stage which is based on physiological parameters. It's usually irreversible, and it is something that we should be able to pick up clinically. So some definitions. So terminal illness is a state from which recovery cannot be expected with currently available treatments, and death is considered to be unavoidable in the foreseeable future. And end-of-life care is an approach to a terminally ill patient that shifts the focus of care to symptom control, comfort, quality of life, and quality of dying with support for the family. Treatments aimed at cure and or prolongation of life can be stopped. So you can see that these are overlapping, partly biologically determined, so that is terminal illness, and partly professionally determined when we change our approach, when we recognize that this is now a situation where death is unavoidable. But I put to you the question, what about, say, somebody with dementia, where we know 3, 4, 5 years in advance that this individual is going to die from this disease? When do we start end-of-life care? When do we call it a terminal illness? Those are difficult questions, and we don't really have easy answers to them. So one of the starting points is to discuss the disease trajectories at the end of life. And this is a classic paper which looked at people who died under Medicare in the US. And in Medicare, people are taken on only after the age of 65. So they randomly sampled these, and they said they were able to cover about 92% of all deaths during the period that they studied it. And look at these graphs. I'll explain them in detail. So in the graphs, you have function on one side and time on the other. And you can see in some the function is good, in some the function is low, and in some it is even lower. So let's look at them. If you look at sudden death, somebody who's functionally completely okay, and then boom, drops down dead. This actually is pretty unusual after the age of 50 years. People who undergo indulge in risky behaviors, and they could be terrorists or soldiers, they could be executives smoking too much, they could be motorcycle riders, riding without helmets, whatever it is. Generally, all those, the implications of all these risky behaviors play themselves out by the age of 50. And after the age of 50 years, only about 7% of people die suddenly. And you have to have a lot of punya, like our long-haired ex-president who literally died when he was doing something that he liked doing best. He was giving a lecture. He had a heart attack and he was gone within half an hour. And then comes terminal illness. This generally refers to malignancy. And here, the numbers here are a little more, a little under 20%. And here, people who have cancer usually are very good functionally until a point where the tumor burden gets out of control. The second chemotherapy fails or whatever. And after that, this is a very steady downhill trajectory. It's called a waterfall trajectory because you know when it will hit baseline. Right. And malignancies tend to peak in their 60s. And you know this gentleman, Mr. Parikar, who had pancreatic CA. Then comes organ failure. So this could be individuals who, for various reasons, develop a failure of one or other major organ system. It could be kidney, heart, lung, liver. This accounts for about a little over 15% of all deaths. Typically, this comes up in the 70s. And these are people who are ill, so their function is already down. And they have this looping or re-entry trajectory where they hit a crisis, maybe get into hospital, come out not as well again, and finally in a crisis. And this, as I said, peaks in the 70s. And typically, since VIPs get organ transplants, the poster boy here is the common. And then people who have taken good care of themselves reach their 80s. And obviously their function is not very good. And they dwindle in a fluctuating kind of fashion over a long period of time. And typically this is people in their 80s and 90s. We call this the dwindling or the frailty and dementia trajectory. And this will be the reward of those 50% of us who take reasonably good care of ourselves and are in good health until we reach our 80s. So, of course, for instance, one of the pictures, I mean, the picture here is that of Atal Bihari Vajpayee. And if you remember, after he lost the election in 2004, we heard nothing from him until he passed away in 2008. There is yet another trajectory that has now been identified, and that is called the catastrophic event or critical illness trajectory. This is somebody who is functioning very well and is hit by an unexpected event, which normally would have killed them. Remember the sudden death trajectory, but they are rescued by critical care and they carry on. So some of them may recover, some of them may recover, but only partly, and some of them may remain at a fairly low level of function until they eventually pass away. Now, this catastrophic event could either be a primary CNS event, so it is either traumatic brain injury, stroke, or so on. But in healthy elderly, it can even be a systemic event. So you will see, say, somebody who's in their 80s, who is very completely functional, get a hip fracture and never really come out of it. So this is what we term the fifth trajectory. Now, if you look at it, the question that comes up, in all these trajectories, can we foresee and foretell death? And should we be doing so? Long ago, Hippocrates said that it is an excellent thing for the physician to cultivate prognosis, so that he will be more readily believed to be acquainted with the circumstances of the sick, so that men will have confidence to entrust themselves to such a physician. Well, this is, I think, somewhat a bit of a marketing thing, but today we realize that prognostication is bioethically necessary, because you cannot have informed consent without an informed patient. And an informed patient is one who knows what is going to happen. The problem is that when we are expected to prognosticate, we are expected to prognosticate honestly, accurately, and optimistically. And I'll come back to these words. Remember that most people find these a difficult combination to handle. So by now you'll have understood that if you look at these trajectories, most deaths can be anticipated. And only a minority, say 10% or less, are unexpected. If you can anticipate their deaths, if people can anticipate their deaths, then they should be able to choose how their last days will be, so that they can live and die in the place and manner of their choice. Does that happen? Not really. So how do we recognize terminal illness? Let's go back to that issue, that question that we opened up right in the beginning. And we now know that there are 4 triggers that should suggest that patients are nearing the end of life. The first is a surprise question. Would you be surprised if this patient were to die in the next year? I'll come back to that a little further ahead. Then there are general indicators of decline, specific clinical indicators related to the diagnosis, and decision. And I'll explain all 4 of these. The surprise question is, in patients with advanced disease or progressive illnesses, if you answer no to the following question, would you be surprised if this patient were to die in the next year? Or you could, of course, change the time frame, but 1 year is probably the most relevant. And this is an intuitive answer. It puts together clinical comorbidities, social and other factors, so that you get a whole picture of deterioration. So for instance, somebody who's going down with a neurologic condition, but where the family is going to do everything possible and they have the means, will have a different period, as opposed to somebody who is in the same situation but has nobody to take care of them. So amongst other things, you get this point that this has to be somewhat intuitive, because that's when you put together everything subconsciously. And the accuracy in oncology touches 80%. In non-oncology, I think 70% is pretty routine, and it does depend on experience. What about general indicators of decline? The first general indicator of decline is decreasing activity. As somebody nears the end of life, they find it more and more difficult to carry on activities of daily living. They are in bed or chair more than 50% of the day. And obviously, this needs to be assessed systematically. And for that, you have, say, for instance, in oncology, you have the Karnofsky performance score. In dementia, you have the FAST scale, and so on. And you can actually put down numbers to this. In addition to this, you have the presence of comorbidities. So if somebody has more than one major illness, then that also predicts mortality and morbidity. And then, of course, as disease advances, symptoms increase. It could be something as, well, you would think it not as significant as constipation and Parkinson's. I've seen patients suddenly pass away with severe constipation. And it's a marker. Decreasing response to treatments, when diabetes is out of control, and you would see this a little further ahead, or when, say, for instance, lung disease starts requiring home oxygen. There are numbers that we can follow. So weight loss greater than 10%, but I often follow this. Once the serum albumin drops below 2.5, and this is when patients start to get edematous and so on. Or when they have repeated unplanned or crisis admissions. How many admissions would you take to count it as significant? People have said 3 over a period of 6 months. Some people have said over a year, but I would say definitely if somebody gets admitted thrice in a period of 6 months, there is something happening. And then you have sentinel events. These are significant events. They can be physical, but they can also be psychosocial. And either way, they carry the same significance. So these are general indicators and apply across the board. When you look at cancer, then when you look at diseases, you get a little more specific. And this is most specific for cancer. So once there is recurrence and or metastasis after initial therapy, basically for stage 4 disease, especially if there are multimorbidities, that's a pointer. The other pointer is if somebody is spending more than 50% of their time in bed or lying down, then prognosis is estimated to about 3 months or less. When you come to organ failure, and if you look at the trajectory of organ failure, it dips and rises and dips and rises. You can see that these predictors start to get erratic and unpredictable. And each disease will have its own set of issues. I strongly recommend everybody to look at the gold standards framework and download the materials that are there. This is free, you have to just register. And this is all taken from there. So if you look at liver disease, the presence of a hepatocellular carcinoma, where liver transplant is contraindicated, and or the patient has advanced cirrhosis with refractory ascites, intermittent encephalopathy, malnutrition, bacterial infection, bleeds, you know that the indicators are pretty poor. But you know that many of these things can still be turned around and the patient can come back from a crisis. So in some ways, it is no longer as predictable as cancer. In cancer, remember that after a certain point, it is cancer biology that takes all the ethical decisions. It takes literally all the medical decisions. In organ failure, and even more so in neurologic conditions, the burden of decision making is on the patient, or if the patient cannot take it, then the surrogates or family and the medical team. And as you can understand, neurologic prognosis is complex. So if you look at Parkinson's, somebody whose drug treatment is not effective, whose independence is gone, whose condition is not responding to medications, is having falls, have psychiatric problems, then we know that they are towards the last years of their life. But it's not as straightforward as cancer, where if you spend more than 50% of your time in bed, then you have 3 months or less. Those are not numbers that you can use in neurology. So, which brings me to the last trigger, and that is decisional. So, whether in multimorbidities, organ failure, or neurologic decline, when somebody has progressive deterioration in physical and/or cognitive function despite optimal therapy, when there are symptoms that are complex and too difficult to control, or swallowing problems leading to recurrent aspiration, sepsis, and so on, or the person is no longer able to communicate because of progressive dysphagia, you may decide not to pursue aggressive or curative treatment, and or even supportive, meaning life support treatment, and to let nature take its course, which is why the fourth trigger is decisional. So let me start off with my first patient. This was a gentleman who I saw much later, but whose story began in 2014, January. He became a little forgetful, and a diagnosis of early dementia was made. He also was thought to have mild depression, was started on treatment. And then as the diagnosis made, as the treatment was started, he asked the doctor, what is going to happen next? Unfortunately, there was no answer given. In fact, he had been pretty active till then. He had given up his responsibility, though, a period of 2 years before this happened, because he said, I can't cope. And husband and wife lived in an apartment complex in a Mumbai suburb with the children in the US, as is so often the case. So 2015, his independent daily routine is maintained, but you can see he's now beginning to deteriorate, and he's asking questions again and again. In 2016, he starts to need supervision, forgetting to brush. Wife needs to supervise, and he irritates his wife because he shadows her constantly. In 2017, he starts having intermittent angry outbursts, doesn't like taking a bath or changing his clothes. Once he wandered outside the building at night, and the building chowkidar just saw him in time before he was opening the outside gate. And in the beginning of 2018, he got admitted with urinary tract infection, found to have a hypofunctioning detrusor, and was, when he was discharged, he had a suprapubic cystostomy. But when he came in, he came in delirium. And in spite of the fact that there was no visible CNS damage, he had clinically declined. Conversation had gone down, and now it is the wife who asked the neurologist, "Ab kya hoga? What will happen next?" And she was told, "Well, this is expected with old age. Live with it." By the end of that year, after a continued decline, he came in with low sodium, and on discharge this time, again, nothing obvious on the CT scan, he was completely bedbound and almost mute, completely dependent for all basic activities of daily living. When I write BADL, I mean transfer from bed to chair, continence, meaning holding your sphincters, self-cleaning, bathing, wearing clothes, and eating. And our gentleman was now completely dependent. And barely a month and a half later, he comes in again with recurrent generalized seizures. Although his seizures were well controlled, well, for whatever reason, he got intubated. There was nothing fresh on the CT. He could be weaned off the ventilator, but again, for unclear reasons, he ended up getting a tracheostomy. So very often it happens that somebody, either the intensivist or whoever it is, decides he put a tracheostomy and move out of the ICU. Well, the tracheostomy got done, but when it came time to decide about a peg, the family balked. They said, "Why? What are we doing?" And that is when Palcare got involved, and that's when I got involved. Eventually, he got discharged for home care. A peg was put. By then, he was literally in the vegetative state. And well, the family asked, could we have involved palliative care earlier? His 82-year-old wife, managing him between us and the family physician, developed bed sores and then finally aspirated and died in March. So if you look at this story, you see that our gentleman could have been given the roadmap at the time of diagnosis. He could have been told that his disease was likely to progress and that the family should start planning. In fact, by the time he came in with the first admission with UTI, the family should have been told that this was now terminal. And at the second admission, in fact, by then, if we had been prepared after that, we should have sorted out goals of care and maybe not even have admitted for seizures. If at all admitted, definitely not intubated. And if intubated, definitely not given a tracheostomy. So think of it, if the last stage of his illness, had somebody been planning, would have been cut short by 2 to 3 months. So you contrast this with this other story, which is, in spite of the bad end, a somewhat happy story. And in oncology, I think palliative care does occasionally have these successes where death is managed well. So this is a gentleman, again from Mumbai, again a daughter in the US, and who develops colonic CA. And he, with a scopy that's confirmed, and he's referred back to his GP and then to oncologist from research. He gets a left hemicolectomy. His post-op discussion with the oncologist is not terribly satisfactory, but well, he goes in for chemotherapy, except that during he had one episode of delirium. But what the oncologist did not know was that he met up with a palliative care physician, because the US-based grandson knew that this was standard of care, and he made sure that this was done. And subsequently, after the chemo was completed, he was on 3-monthly follow-up with the oncologist. This was, unfortunately, the follow-up PET CT got bad news. There were extensive metastases in the liver and lungs, and the expected survival, he was still active at that time, was over 4 months. But I think they told him 4 to 6 months. He was offered palliative chemotherapy with targeted therapy, EGFR inhibitors, and he was told that the best case would be 24 months of survival, but median, much less. And he decided that he did not want it. He hadn't had a good experience with the previous chemo, so he said palliative care. And palliative care did home visit, hospice care was set up at home to manage symptoms. And then look at the rest of the story. He had prolonged discussion with the palliative care team together with his wife and his daughter and grandson participating. The grandson had just gotten a new job, but he got 2 months of leave so that he could fly to Mumbai to take care of his Nana, who was now in bed most of the time. And anticipatory grief was discussed, advanced care planning was done. In May 2018, he was completely bedridden, including toilet. And it was now that the daughter could get the leave to come in. And literally, he waited to meet her, slipped into coma the day after the daughter reached, and after greeting her, he passed away. So you can see the differences between these two deaths. In cancer death, there's a defined trajectory and prognosis. Function is maintained until the last stage begins. Although the tumor makes all the decisions, the patient is awake and is largely able to make his own decisions or her own decisions almost till the end. Admissions can be avoided, and if there is transparency, patient and family retain control. In neurologic or non-oncologic deaths, the trajectory is erratic, prolonged. Recurrent admissions may be unavoidable. And the problem, especially in dementia, is the person who is expected to take charge, the patient himself or herself, departs fairly early. And expensive and avoidable ICU care at the very end is often the case. We change gears here to old age. Remember that human life expectancy is not expected to go much beyond 80 years, regardless of whatever you may read. And even there, you do have the concept of chronologic age versus biologic age. So you may have individuals who are 90 and look 70, and you have people who are 70 and look 90. So we need to keep that in mind also, but roughly around about 80 years is where all of us need to think that, well, maybe it won't be much longer than that. And we have the importance of sentinel events also to pay attention to. So let's hear out this story. This is when it started, she was 80 years old, retired homemaker. And her husband was 87 at that stage. In 2014, she moved to Nasik, which is a city close to Mumbai, because her only daughter stayed there. Her diabetes was poorly controlled, and she had episodes of hypoglycemia and DKA. Otherwise, she was okay. The daughter said, no way that I can manage things at Mumbai. You have to come and stay near me. So she did that. They did that, and they settled it. Had an active social life. And for about a little under 2 years, things went well. In April 2016, she had febrile diarrhea, collapsed, needed admission to ICU, but discharged in 5 days. So one illness. Second illness in 2016, fall at home, fracture left neck femur, hip replacement, transient post-op delirium, recovered well, but walking with walker at 3 months. So you can see something is happening. In 2017, next year, this is about 6 months after her, a little less than a year after her first illness, her first major illness. The husband collapsed after 3 days of vague chest pain and mild fever, turned out to have lobar pneumonia, had multi-organ failure. His wife confirmed, do not intubate and do not attempt resuscitation orders, and he passed away 48 hours after it. Why did she do that? When she had had a bad illness, both husband and wife on their own spoke to their daughter and made it clear that there were going to be no heroic measures for either of them. In fact, they both wanted to be allowed to pass away in peace and their bodies to be donated to the medical So after her husband passed away, her granddaughter moved in to live with her, and in fact, she seemed to bounce back. Except that about 8, 9 months later, her diabetes was, as it is, pretty bad. She developed multiple superficial soft tissue abscesses. She was admitted twice, given IV antibiotics. And about 3 months after this started, after the second course of fairly heavy duty IV antibiotics, it was obvious that the abscesses were not just vanishing. So she was discharged for home care with daily dressings. And she asked herself, what is happening? She was told the medicines are not working, so we are going to try this. Her decision was, I will not go back to hospital again. And she was a pretty strong lady. She said she refused strong painkillers, only paracetamol once in a while. And then you could see the decline beginning. By end April 2018, she was in bed most of the time, needing help with basic activities of daily living, except she could eat. Appetite started to decline. Second week of June, she became delirious, confused, little restless, moaning on turning over, cold hands and feet. So vital signs declining, became incontinent, and 3 days later, she stopped speaking. The day she stopped speaking, she stopped breathing the same day. Now, if you look at the third story, how would you predict mortality? So people have been working on this issue for quite a long time, and there are something like about 6 or 7 mortality risk scores for prediction of 1 year mortality in older adults. And and they don't seem to overlap, they don't even seem to match. So people don't uh, rely too much on them, except that when you take only one of these scores, at least it allows you a framework for making decisions. So I use the Walter Index. This was published in 2001. And of all of those that were reviewed, even in that lot, it was probably the most predictive. So let's look at how you can make a score here. So if you have a male, that gets 1 point. If all basic activities of daily living are dependent, you get 5 points. If albumin drops below 3, if you remember earlier I said 2.5, here if it is below 3, you get 2 points. If you have congestive heart failure, you get 2 points, and so on. And what happens if you add these points up? If you have 0 to 1 points, then your survival is like the population. But if your points are 6 or more, your likelihood of mortality in the following 1 year is more than 60%. And I would think probably about 70%. So what does this mean? This means an individual who's 70% likely to pass away in the subsequent 1 year. So if you take a cohort of 100 people, say 65% will be gone in 1 year. Out of the remaining 35, again that 65%, again that 65%. So you know that this is a cohort which has a close to 95% or more likelihood of being gone in about 3 to 4 years. And this is something that we don't always look at, nor do we predict, nor does the family ever get told. Why? Well, before the middle of the 20th century, diagnosis, therapeutics, and prognosis were equally important functions. As medical treatments improved, the skill of prognosis declined in teaching, in research, and in practice. And you can actually see it in very old editions of our textbooks. But prognostication is not just figuring out how many days. It's not just foreseeing, it is also foretelling. And when you foretell, you have to combine honesty, accuracy, and optimism. And this needs communication skills, because it is not easy to, this is a triangle and you have to make it into a circle. What are these? What do you have to communicate? The first, one more small point, and that is that I believe that if you do not commit to foretelling, your foresight also at risk. So prognostication is a joint function, foreseeing and foretelling, and you do both for your skill to sustain. Okay, so what do you talk about? The first is you talk about goals of care. This is something that we actually routinely do. We combine it with patient education, and these are discussed with the patient and family. It's almost like educating them about what is happening, what will happen, how will it go, and so on. It is done over multiple visits, and it supplements the usual discussion about treatments. If you look at goals of care for medicine in general, we effectively have three goals of care. The first is longevity. Obviously everybody wants to live long enough. Then function, you want to maintain function, and last, you don't want pain and suffering. So what comfort? And it's to get patients and families to actually give their attitudes. You have to watch for statements that come up as you talk to them about what is happening. So possible statements could be, for longevity, her father lived to 90. So the value would mean living as long as possible, not giving. But it could also mean living till a specific event or milestone. And it could also mean a preference, being able to decide when it is time to go without becoming a burden. Similarly, for function, somebody might say, I don't want to be dependent. And again, there, the reason is to maintain physical and cognitive activities, participate in relationship, and so on. But they might have a specific activity that they enjoy, and if they can't do it, then life has no meaning. The last, of course, is pain, suffering, avoiding futile interventions, and this is where we can help quite a bit by palliative care. But it could also mean that, for instance, suffering is looked on as almost religious, that if you are undergoing suffering without complaining, you are doing something that is spiritual. So you have to discuss this with the family, and then these issues kind of come out. It's not something that takes long discussions, but if it's a familiar patient, then it is not very long before you do understand this. And then you kind of explain and communicate this, find out how much they understand, how much they want to know. You may have to explain uncertainty. Probably the simple, best, easiest issue that you can sort out is find out the patient's wishes about place of care. So when your illness becomes more severe, and perhaps we are looking at sometime, say, some months from now, where would you want to be? Would you want to go back to this hospital, or would you want to be at home? And if the patient is very clear, find out if the caregiver agrees. Of course, these wishes and plans may change. If you have done this, then you have embarked on what is termed advanced care planning. Advanced care planning is an umbrella term for goals of care, the living will. But the most important is choosing a proxy decision maker, because towards the end, most people can't make their own decisions. And eventually, you combine patient and family inputs with clinician input to make appropriate in the moment decisions, and we call that shared decision making. Specific end of life decisions, the first, as I said, is the preferred place of care or death. And then there are decisions about life-saving treatments like CPR and so on. But don't forget that mode of feeding, when the patient is unable to take oral feeds, especially rice tube and peg, are also life-sustaining treatment. And parenteral medications, other than those required for symptom control, those are also LSD. If you do it right, it improves the patient's quality of life and they get a sense of control. There is decreased burden, conflict, stress amongst the family members. and the system is not stressed by unwanted medical interventions at the end of life. The challenges are everybody fears death, doesn't like talking about this. But why do clinicians don't do it? And that is, there are other reasons, but everybody says, I don't have the time and I don't know the prognosis. And as I said, these are not really okay. So clinicians either do not see it or see it and ignore it or don't know how to handle it. And as I said earlier, if you do not know how to foretell, your foresight will atrophy. And so both of them are gone, your prognostic skills are gone. You can't blame the families. This is not their business. This is our business. To communicate, is a learned skill, like surgical or diagnostic. It takes training, it takes practice, it takes assessment and certification. And then when you come to performance, every time you do a procedure, you prepare for it. After it is done, you review and reflect on it. Why don't more senior doctors undergo this training? Well, this is me trying to explain to my senior colleagues that regardless of their years of experience, they do need to be trained specifically in communication skills. So how do we know when a person is actually dying, or what we term actively dying? These are purely clinical symptoms and signs. These are the hours or days preceding death, during which time the patient's physiological functions wane. We have to prepare the family and caregivers for the natural process of dying. And the care has to be multidisciplinary and holistic. And it extends to after-death care and bereavement support also. Months to weeks before death, and we term this pre-active dying, the patient begins to physically and psychosocially withdraw. You know that ambulation declines. They start withdrawing from family and friends. They may occasionally become incontinent and they start losing weight. All of these are indicators that we've spoken about earlier. Weeks to days before death, the CNS starts to get affected and the patient starts to lapse intermittently into delirium. Vital signs also start to drift downwards, and the patient is usually confined to bed with reduced communication. This is weeks to days. Days to hours before death, the vital signs also start to go down, and we call this imminent death. Consciousness goes down consistently, breathing becomes irregular. Because secretions cannot be swallowed, you get the death rattle. Hemodynamic changes appear, the face may relax and may change color. But for me, probably the one single sign that tells me that it is now ours is the appearance of gasping. That is mandibular movement as a part of respiration. And we still don't know why it happens, but people think it is because of brainstem and medullary hypoxia. It's been identified in people who had cardiac arrest and get CPR and then are revived, and so on. So that is the assumption, but as you can understand, there's no way of proving it. So when we are taking care of a patient in the last 48 hours, you have to ensure the patient's comfort, make the end of life peaceful and dignified, make the memory of the dying process as positive as possible, focus on symptom management for comfort. One of the important ways to do that is to remove unnecessary medicines and prescribe in anticipation medicines for symptoms. One of the major challenges is of oral intake. Appetite goes, there is aversion to food. In addition, there may be stomatitis and pharyngitis and so on. And families have to understand that feeding is no longer a priority. People do insist on feeding tubes, but they do not enhance survival or quality of life at the end. In fact, patients get agitated, they need to be tied down, and they're more likely to have ulcers. And they do not reduce the risk of aspiration. So you have to look at the patient's best interests and quality of life. If by chance the tube is already in place, then review rate and volume so that the patient doesn't get overhydrated and puffed up and so on. The best thing to do is careful hand feeding. Provide the items of the food that the patient likes, and it really doesn't matter whether it's sweet or salt or whatever, preferably mashed. We usually don't recommend supplements. And you alleviate symptoms of thirst with good mouth care by putting ice pieces and so on. The family has to be told that the body is shutting down and intake is going down accordingly, not the other way around. Typically, people need about 1 liter per day. And if needed, you can even give it subcutaneously. If somebody is passing urine about 4 times a day, then it is very likely that they are maintaining this 1 liter figure. As we said earlier, we avoid any artificial measures at this stage. All medicines that are not required for symptom control should be stopped. There may be occasional important medicines that need to be continued, and then they maybe have to be subcutaneously. IV antibiotics, aspirin, statins, vitamins, even diabetes medicines, antidepressants, all of these can go. Remember that you're giving aspirin and statin for a decade ahead. What is the point in giving them at this stage? Insulin and oral hypoglycemic medications become a little tricky, but we generally avoid oral hypoglycemia simply because they may contribute to hypoglycemia. The sugar as it is with no intake is drifting down. Then the symptoms that bother the patient and family have to be tackled. Pain is number one, but delirium comes close behind, and then incontinence, dyspnea, nausea, vomiting, and so on. For treating them, you need to be able to deliver medications. And the most reliable route, the most commonly used route is the subcutaneous route. Intravenous, difficult to maintain lines. Sublingual, transdermal, rectal, intranasal are not as predictable. Pain is the most common symptom. If you cannot assess it verbally, if the patient can't say it, then you use validated scales like PainAd, which uses non-verbal indicators. You have to have access to opioids. And as I said earlier, it preferably is the subcutaneous route, with maybe the requirement of titrating rapidly if there is severe pain. If the patient is restless, assess the environment, look for the 3 big ones: urinary retention, constipation, and pain. And in fact, very often the patient may be underdosed with opioids rather than the other way around. Medications, especially anticholinergics, can contribute. You make sure that the patient gets decent natural stimulation, remove tubes and other things that irritate them, stop stimulating noise, and basically use these non-pharmacological measures to reorient and quiet the patient. But if that doesn't work, then haloperidol is the treatment of choice. And remember that benzodiazepines are contradictory. They can actually be activating, can worsen delirium, and are never the first choice for managing these patients. What about breathlessness? There are 4 principles. Correct the correctable, use simple air movement on the face, reduce the perception of dyspnea with morphine and anxiolytics. And if a patient has intolerable refractory breathlessness, then and then only you use what is termed as palliative sedation. So you can correct the correctable with pleurosynthesis, diuretics, and bronchodilators. Again, in nausea and vomiting, the first line again is reverse the reversible. And here the reversible ones are constipation, hypokalemia, and hypocalcemia. Failing that, the first line drugs are metoclopramide, but you can use even haloperidol. Ondansetron may not be strong enough. And then you may need to give them steroids, lorazepam, and other drugs. Olanzapine is a reasonably effective second-line drug. What about pooled airway secretions, the death rattle? Now, this can be either type 1, meaning in the pharynx because swallowing reflexes are gone, or bronchial secretions cannot be coughed up. Once this appears, it's a predictor of death in 50%. And up to about 75% within 72 hours. The family has to be educated that this is not causing any distress to the patient. And the best management is non-pharmacological. You reposition them so that the neck is extended or laterally positioned. Remove the secretions by taking a gauze piece and hooking the finger and swiping it out. Suctioning is avoided because it actually irritates the mucosa and stimulates more secretions. If at all pharmacological means are required, then it's glycopyrrolate that is preferred. We avoid scopolamine because that has anticholinergic side effects. Nursing interventions that are important are mouth care, pressure sore prevention, Foley's catheterization. I think towards the end it is often required, and monitoring for constipation. And then you prepare for the end. And here, most people, of course, just drift away and the heartbeat and breathing just stop. But occasional patients will take one of these two dramatic routes. The first is fits or epileptic seizures. This occurs in neurological and even other cases. Here, what you do is do not force things into the mouth. You have to ask for subcutaneous midazolam or another subcutaneous anti-epileptic drugs. There are multiple, including Gardnerol and even phosphanatoin. If this is the end of life, clearly determined, then basically suppressing visible seizures is a good point to reach, because visible seizures distress the family. And eventually the patient becomes unconscious, quiet, and will stop them. The other dramatic event is the blowout hemorrhage. This occurs with oral malignancy because the neck arteries get infiltrated. And when you know that this is likely to happen, this must be discussed in advance. When it starts, steady pressure should be applied with dark towels, preferably green, because that doesn't show blood. And the patient must be quickly sedated. Again, this also doesn't last very long. In patients whose symptoms are refractory, any one of them, breathlessness, pain, so on, you can use palliative sedation. Now, palliative sedation is the use of sedative to provide light sleep and comfort. You're not altering the natural process, you're upholding the sanctity of life, but death may be hastened because sedation can do that. And we call this the double effect. And this is different from euthanasia, where the sedative is disproportionate with the intent to terminate life, and death is actively accelerated. Remember that the family may be suffering as much as and maybe more than the patient, and you have to address their multiple needs by involvement of the palliative care team. When death occurs, you have to confirm it. Ideally, wash hands, confirm identity, watch for signs of life, response, feel for the pulse, and then exit together with documenting the time. Remember, for all of us, we have rights as human beings. We have rights in medical care. We also have rights at the end of life. Probably the most important is to be treated as a living human being until death. The next is to participate in decisions about your care, to die in peace and dignity, not in pain and not alone, to retain individuality and not be judged, and to be cared for by caring, sensitive, knowledgeable people who will attempt to understand your needs. There are much more, there's a pretty longer list, but these were the ones that really appealed to me. Once death has occurred, you need to visit the patient again, where opioids have been used. Unused opioids need to be collected back, and the family needs support. One of the ways is to explain to them that grief will come in a kind of a wave-like character. It will come up and go down. So, and this can go on, normal grief can go on up to 6 months. Throughout this period, anticipatory guidance prevents panic. The family needs that. If you tell them what is likely to happen, they can prepare. You have to be available to answer questions. If religious concerns or wishes of the patient are there in terms of funeral arrangements, we have to help with that, or at least make sure that they can be done. And enlist help from the family, from the medical team and the community. Remember that bereavement is the period during which mourning and grief occurs. Grief is the natural distress experienced. Mourning is the outward expression of this. And a patient with serious illness will have had many losses throughout this period. So people experience grief uniquely based on culture, religion, the nature of loss. Is it the sudden death of somebody extremely close? That can be very, very hard to take. But grief can also occur before the event, and it's called anticipatory grief. We look at acute grief, which occurs following the death or loss of a loved one. It basically involves an evolving process of adapting to life, and symptoms gradually decline over a period of several months. During this period, within the period of a day itself, the feelings can peak and subside, and peak and subside. So we call it a wave-like character. Eventually, the sadness, the understanding of the finality, the consequences of the loss are all accepted and assimilated into the bereaved person's daily life. That's integrated. Now, when grief persists for an extended period of time and exceeds expected norms, typically we take it as anything that exceeds 6 months. We call it complicated grief. And it is the responsibility of the palliative care team to continue support for at least a year so that caregivers who are at risk of complicated grief can be identified, and appropriate psychiatrists, counselors can be connected. So remember, terminal illness can be identified. We have to shift the focus to symptom control, comfort, and quality of life. And the active dying phase allows us to prepare the prepare the family for the patient's death. The family has to be supported before and after death as well. So if all of this, and if you heard me, so you realize that this is something that we have been seeing, doing part of all the time, yet we've not been taught about it. And yet the medical profession actually shies away from these issues. When you ask patients and families, they see perverse incentives. They say corporate hospitals want to suck money till the end, so they don't want to get into these issues. And when you ask doctors, they feel that this is because of no legal clarity. There is no clear law requirement for this, that if you do this, if you don't do that, you will get punished or whatever. And the third is that we are afraid of criminal charges and litigation. The last is the standard excuse that many doctors give, except that it is no longer true. But what nobody says is that we lack two things. One is, of course, prognosis is not easy, but as I said, if you pay attention to it, it becomes progressively easier. The second thing is lack of capacity. We are completely not trained in palliative care, end-of-life care, or communication skills, so we just don't know how to handle these situations. If you look at the way we function, the framework is that we follow. We have a way of practice. Typically, societies make guidelines. There are policies that may come from government as well. On the broader overarching frame, there are ethics, and you may have heard this term from the Supreme Court recently. It's called constitutional morality. Between the two of them, laws that are passed by the government and judgments that are passed by the judges actually frame the limits of what we can do and can't do. If you look at not just India, the rest of the world, medical progress really began from the 1950s onwards. Before that, doctors know best, and there was no real question of human equality. But in the 1950s, with ICU care and so on, people started to survive serious illnesses, and conversely, they also started to pass away in ICUs. and hospitals. And with that, we began what is called the medicalization of death. Medical paternalism tended to decline as patients became more aware. And the first, of course, was the necessity for informed consent. But this spread into the last phase of life. Living wills were first discussed by a human rights lawyer. And for various reasons, the USA became the world's laboratory for all these discussions and instruments. Partly it was because the various US states passed their own laws, it became a little competitive. And from the other side, from the United Kingdom, palliative care was also spreading across at that time. We have 4 pillars of ethics: autonomy, beneficence, non-beneficence, and justice. There are others that are also included here: dignity and honesty. The issue is, how do you apply them? How do you combine them? And when you try to combine them, we use what is called the 4-box model. I'll leave that to you if anybody wants it. I'm happy to share that with you, but it's something that you must read. I've already told you that the legal framework for end-of-life care begins with the Constitution of India, and it passes through various judgments, and there is only one law, and that's the Human Organ Transplantation Act. I have been involved with this issue since 2011 because I was on the medical panel that examined the case of Aruna Shanbag. And by about 2015, the 3 national medical associations of neurology, critical care medicine, and palliative care came together to see what we could do jointly, because we thought this was something that doctors had to take some responsibility for. In 2011 itself, in the Shanbag case, the judgment was pretty clear about decriminalizing this whole decision-making process. And it actually said that if somebody who was being kept artificially alive, it was possible to withdraw support. Of course, that patient, Aruna Shanbag, they confirmed that she was not brain dead as we had suggested. And since the nursing fraternity of KEM Hospital did not want withdrawal, there was no question of withdrawal. There were documents that came out from the ISCCM and Indian Association of Palliative Care, but nothing really happened until the 2018 judgment. This judgment very clearly gives the constitutional basis of the right to refuse treatment. The Supreme Court said that a competent person who has come of age has the right to refuse specific treatment or all treatment or opt for an alternative treatment, even if this decision entails a risk of death. You can treat an emergency only when it is not practical to obtain the patient's consent and his or her life is in danger. But where a patient has already made a valid advance directive, which is free from reasonable doubt, specifying that he or she does not wish to be treated, then such directive has to be given effect to. This is the law of the land. Except that this is a judgment, and it doesn't say what happens if you don't do this. How can you be punished? So at this moment, effectively, that's the constitutional right. From 2018 to 2020, our group worked on multiple documents. But there was one thing that we had a problem with. The 2018 judgment, although constitutionally it clarified everything, procedurally it made everything completely complicated. And it put in a complex process, so complex that nobody really bothered with it. And in fact, we believe that even people who are beginning to follow ethics shied back. Until the 24th of January 2023, when we had the clarification of this judgment, and this clarification is what I'm now basing my suggestions on. Remember that this whole business is about patient self-determination and autonomy. Only a few countries have this legislation. In fact, comprehensive legislation is available only in maybe about 4 or 5 countries. In fact, not really. I think no country has comprehensive end-of-life care legislation. But about 4 or 5 countries have fairly good legislation. So as of now, it is these judgments, the 2011, 2018, that are the law of the land. Remember that although we pay lip service to autonomy, there is no autonomy without adequate information and communication. So foreseeing and foretelling. I told you earlier that this needs to be learned. And what happens if you fail on this? Now, in India, we are beginning this journey, so maybe it's difficult to. I mean, we don't have any knowledge of what will happen here. But if you look at the US, most of the litigation is for wrongful life. This is because people who write end-of-life instructions and do not get them followed, the families are likely to sue. And they're getting big chunks. As far as we are concerned, poor end-of-life care is one of the major causes of the systemic distrust of the medical profession in India. And now we have no excuses for not addressing this issue. Think of a patient who has a bad illness, has expensive interventions, and finally passes away in hospital. When the family gets back the dead body and gets debts with it, and their memory of the suffering that he or she went through, their patient went through, they are not going to be very charitable to the medical profession. So how do we proceed with foregoing or withholding or withdrawing life-sustaining treatment? Ideally, the hospital should have a clear policy for this. And from the Supreme Court, basically, the suggestion is to make 2 committees. Now, the first committee is basically the treating team. It means that the primary consultant, together with at least 2 other consultants, not junior doctors, should confirm futility, that there is no point in continuing here. Then, on the patient side, you confirm consensus, confirm their hierarchy. The hierarchy is if the patient is competent, that is first. The second is if there is a written advance medical directive, that's second. And the third is if these 2 are not possible, then surrogate decision makers take up. And you document this in completely, put a detailed note, and it is signed out by the appropriate surrogates and these 3 consultants. This is to make sure that this is not a unilateral decision by any one doctor. I think it's a pretty important and essential requirement. The step 2 is that this has to be reviewed by the second committee. These are 3 doctors from the same hospital, but one of these 3 is nominated by the government authorities. And these 3 doctors also complete their review within 48 hours and communicate back to the primary team. So this is as far as what happens when somebody comes in without an advance directive. What about the rest of us? It's important for us to make a valid living will or advance medical directive. You have to begin by speaking, choosing your surrogates, and make an advance medical directive. It has to be signed in front of 2 witnesses and attested by a notary. If you look, the Pallium India website has the standard format, which you can use to make this document. And it has various elements to it. We are not getting into that. It's available at other websites also. And as of now, this is the standard document for India, though obviously there is no legislation, so this is more by convention. Once you made this, then you have to show it to every doctor you consult, because then you will find out if the doctor is willing to accept and support it, can find out their hospital's policy, and more importantly, will know your wishes. What if this is not done? What if we just go by default? and let decisions be taken by default. Well, remember that we now have the means to keep the body alive indefinitely should we choose to do so. In 2018, 3 nonagenarians, meaning people in their 90s, and then in 22, a fourth passed away. Okay. Of the people who died in 2018, the Barbara and George Bush passed away in their own beds. And you will see photographs of them literally lying in Darbar with uh, dogs, cats, children, grandchildren, friends, everybody around them, and they are smiling. And what about Atal Bihari Vajpayee? He died on ECMO, extracorporeal membrane oxygenation in the AIMS ICU after I think 10 or 15 days in the ICU. And Lata Mangeshkar, well, with COVID, got intubated not once, but those incomparable vocal cords were raped the second time. So what this means is that if you are an Indian VIP, you are actually condemned to torture before death. So the take-home messages for you is that except for death from trauma, dying from chronic disease and cancer follow a predictable trajectory. With clear and empathic communication, end-of-life care is possible. Anticipatory guidance is necessary, symptom management is necessary, and if you pay attention to the bereavement phase, you facilitate the re-entry of the family back to their lives. I'm going to stop at this point.